Hello everyone, good evening. I'm Purnima from Fertility and today we have Dr. Mangla Devi from Smile IVF, Smile Baby IVF, Bangalore. She is director over there. Good evening, Dr. Mangla, and welcome
Good
to our
evening,
platform.
Purnima. Good evening.
So today we are going to talk about very different term. I hope you all must have heard it somewhere when you are going through your motherhood journey through IVF. That is assisted hatching. When we first heard about this, I was like, what is this? Assisted hatching or laser hatching? Is it similar or they are different or this hatching technique really going to help you to increase your pregnancy chances through IVF? So, Dr. Mangla Devi, we really want to know about this new term, new technology. What exactly is this hatching?
As you all know, the egg or the ovum in a woman, it has a shell. Okay, so that is what we call as zona. So this shell sometimes is a bit hard. So when we do an IVF or an ICSI, we artificially inject the sperm into the egg, right? So we bypass this zona through the needle. Now, so once the embryo is fertilized and it starts developing, it starts multiplying, it travels through the tube with the shell intact and comes to the uterus. And this shell, meantime, it hatches out of this shell. Okay, and then implants into the uterus. But it so happens that in certain conditions, the shell might be too hard, and so implantation doesn't occur. So, assisted hatching defines those methods which we can use to hatch this shell, so called shell, and thus enable implantation. So obviously, in cases where there has been IVF failure, this kind of helps in implantation and thereby improves the success rate.
Okay. So, ma'am, what are the cases when you advise your patients to go for this hatching technique?
Usually, in patients who have had, like I already mentioned, recurrent IVF failures, like we do a simple IVF or ICSI in patients initially, okay, and when these IVFs fail repetitively, then we offer assisted hatching to our patients. And in some cases, where in older women, so well above 38 or 40 years of age, and sometimes in frozen and thaw cycles. So, because of repeated freezing of the embryos and thawing, the egg the shell of the egg, the zona, becomes hardened. So even in these cases, we advise people to go for assisted hatching.
Okay. So, means this assisted hatching and laser hatching
Okay.
both are similar.
In the sense, well, as of now, it has become synonymous with laser hatching. But assisted hatching means that this assistance can be given through several means. So we can either use mechanical methods, as in we can, prick it with a needle and try to hatch and create a hole artificially. We can also use a chemical, an acid called acid thyroid, to on the shell, so that it creates a gap and helps the shell to it helps penetrate the shell and thus assists in hatching. Or we can use what are known as lasers. So lasers are more accurate, and these are the latest kind of thing, where they require very little skill. And in terms of when you apply the chemical or mechanical methods, the skill of the embryologist becomes very important. But lasers have made it all easy now. So with a laser, the process of hatching is simplified to a great extent. So we use this laser to hatch this shell of the egg. So that is why it is known as laser assisted hatching, actually, LAH. Yeah.
Okay, okay.
So that's most
So,
commonly used now.
right.
Yeah.
So, for this hatching, like if the lady age is above 35 or 34, or the lady has the history of recurrent IVF failures.
Yeah.
So then you suggest this technique.
Yes, and in people who have undergone repeated frozen and thaw cycles, freeze cycles, which most of us do nowadays. So,
Right,
and
right.
if they've not seen failure, then we would prefer assisted hatching.
But ma'am, is it advisable for a lady who is going for her fresh IVF cycle to opt for this hatching technique?
Not necessarily, because this is an additional expense. As you know, IVF is quite
Right,
expensive as it is. So, unless
right.
indicated, we need not go through all these things. And there's always been a doubt whether these methods can lead to abnormalities in the embryo that develops,
Mm,
or if there are any side effects because of these methods. So,
right,
as of now, studies have proven that it has not really caused any harmful effects. But still, it's always better not to intervene unnecessarily. When you can get success in normal cases, I think we can, even the simple IVF and ICSI procedure should be sufficient. So I wouldn't
right,
advise anyone to go for it in a primary IVF cycle.
right. Because certainly age factor and yes, cost factor is very important in this.
Yes, yes.
Uh, so, ma'am, if you have, like, lady have a number of embryos frozen,
Mm.
let's say she has 5 or 6 embryos frozen, and if she wants to go for this hatching technique, so
Mm.
what would be advisable for her? All the 6 embryos should be put into this hatching, or some
See,
numbers should be without hatching?
actually, you can make out, when you observe the embryo, the quality of the shell, the thickness of the shell. So you can gauge the thickness of the shell. The embryologist can easily identify, in most cases, which of these embryos are likely to not hatch spontaneously. So
Okay.
we can decipher that. So when you kind of make out that, okay, these eggs are not going to hatch, and we have 6 embryos, and all the 6, the thickness of the shell or zona is more, then probably we would advise them in the first attempt itself to use assisted hatching on all the embryos. But otherwise, most often when they are likely to expand and hatch spontaneously, we wouldn't. So I would say that if it's a primary IVF cycle, irrespective of the age, I mean, they may be 35, but that's more like a theoretical figure. So irrespective of the age, we can gauge, so which of these embryos are unlikely to hatch. So probably we could use a first cycle, we can transfer them and freeze the rest. And if at all these don't result in a pregnancy, then we can use assisted hatching in the next cycle.
Okay. And one more thing, as you told me that it is not necessary and embryologist can make out. So what about is it the 3-day embryos or blastocyst? What would you advise?
We prefer blastocyst at the stage of
Okay.
blastocyst, because
Okay.
you even if you use this, see, this shell is actually protective. So in the normal fertility cycle, so this shell kind of protects the transit of the embryo from the fallopian tube into the uterus, because the fallopian tube is where fertilization actually occurs. So it
Right.
travels through this tube, so it protects it from the other external environment in the tube, other chemicals, infections. So it's actually protective in nature. So when it reaches the uterus, say by day 5 or day 6, that is when the process of hatching occurs naturally. So so blastocyst is also around day 5, day 6, right? So it kind of mimics the natural procedure better. So which is why we prefer to do it on a blastocyst cycle.
Blastocyst stage.
Yeah.
So that was kind of new thing for me also, because till now I have heard this technique, read about it, but yes, day 3 or day 5. That
Yeah.
is most important thing.
Yes.
So we'll take a query now. Married since 4 years and trying since 2 years, but no luck. All the blood reports are okay. Serum prolactin okay. AMH 3.5. My cycle is 24 to 25 days, which is always regular. HSG accurate,
Accurate.
arcuate shape uterus. Husband semen analysis is also fine. Undergoing assisted cycles with Letros from last 3 months. Please suggest if arcuate shape is one of the reasons for the delay. Should I still wait or go for IUI or IVF?
Hello. Yeah, see, the arcuate shape of the uterus is definitely not a cause for infertility. So in this case, everything we know seems okay, but so this probably belongs to this small category of unexplained infertility, where all the factors seem okay, and definitely the arcuate shape is not contributory to your fertility. However, I would consider that since you've been married for 4 years and have been trying regularly to conceive, if it has not happened happened with 3 cycles of ovulation induction with letrose or clomiphene, then I would generally suggest that you go for IUI.
Okay.
So
So
this is what
because
I think should be preferred.
right.
Of course, I don't
And
know the age of the patient. It's not
no,
mentioned here.
I'm also looking for that.
Yeah, yeah.
The age is not mentioned. Yes,
Not mentioned.
obviously,
Yeah.
with the time, age is going to increase. So please look into it and how to
Yes.
proceed further.
Yeah.
Consult with your doctor first. So here I have one more. My age is 28. I have PCOS. After 7 unsuccessful pregnancies, I have opted for IVF. After blast, the embryo were 11. So do I need to go for laser?
I don't think you need to go for laser in the first shot itself, like what I explained, unless they have done a procedure called IVM or in vitro maturation, which usually people consider when they have PCOS. But if it is the regular IVF ICSI cycle, then since you have so many embryos, I would think that you can go for spontaneous, at least normal embryo transfer. And if probably that fails, then your subsequent frozen embryos which you have, you can do assisted hatching on them.
Right, because unnecessarily there's no way to spend so much of amount on
Exactly.
every. So, ma'am, how is the cost of this hatching?
Well, the hatching, if you do it in one set, say one cycle, so we'll probably have to do it in each cycle just before transfer, right? So for each cycle, it would cost you at least anywhere between 35,000 to 60,000, depending on where and how you're getting it done per cycle.
Oh,
In addition to the cost of IVF.
normal cost, right,
Yeah,
right.
the
So
usual
quite
cost. Yeah.
expensive,
Yes, yes.
right.
And not every center may have it as well. So you'll have to plan where you're going to get it done. So,
Okay,
it
so
has to
is
be
it
thought much
possible
ahead.
that okay, so hospitals also transfer the embryos for this assisted hatching to other centers?
Well, if you do that, then the transfer has to be done in that center itself. Because once you hatch the embryo, then you'll have to transfer it, right? So then probably you'll have to do your
Hmm.
entire transfer cycle in a different place.
Right, right, right.
Yeah.
So please look into these factors because yes, a small mistake, or I could say the unknown factors also affect your precious embryos. Let's take another one. Age is 34, have adenomyosis along with endometriosis. Uterus size is 10 centimeters. My tubes are clipped. In first cycle got 5 A grade oocytes. First transfer 3 grade A, 3 embryo transfer, but miscarriage happened. Second transfer 2 A grade blastocyst, but it failed. Second cycle I got 12 oocytes, 6 grade A, 2 grade B. Third cycle I got 8 embryos, 6 A grade, 2 B grade, all are grade 3. Total 16 embryos frozen. Next, I am planning to go for 3 months down regulation and then day 3 transfer.
So I don't know what is the query here.
So, like she's asking that is it like what she's going through is right way to follow the procedure?
I didn't follow why she did not transfer after the second cycle. See, she's got some oocytes second cycle, 6 grade A, but I suppose they're not transferred. And third cycle, she's got 8 embryos, out of which again 6 are A grade. So she has frozen all these embryos put together. So that's 16 embryos right now. So I guess 12 are grade A and 4 are grade B.
B.
She's planning for going for down regulation and transfer, but why day 3 transfer? I would prefer a blastocyst transfer because a blastocyst transfer is any day better than a day 3 transfer. And the very fact that you allow the embryo and the embryo grows till day 5 shows that by method of natural selection, these embryos are bound to be more healthy than a day 3 embryo. So I may have 12 day 3 embryos, but only say at a ratio of 2:5 may progress to a day 5. But obviously, these are the healthiest embryos. If they've reached till day 5, then they're quite healthy. So that's one thing. So I would prefer a day 5 transfer. And then apart from that, I would think that I'm supposing that you're pooling these embryos to probably do a PGD, PGS genetic test, because sometimes when IVF has failed consecutively, so this test is done to identify which of these embryos are healthy. See, what we do, this grade A, grade B, grade C, is a morphologic grading. That is, we grade it by looking at certain qualities of the embryo. But this PGS, PGD kind of tells us if there is something inherently wrong with the embryo. So if the PGS, PGD says that these embryos are healthy, then the success automatically increases because they're obviously healthy embryos. And yeah, in your case, your uterus is a little big in size, and I'm assuming that apart from that, there's nothing else. They must have done a hysteroscopy and evaluated the interior of the uterus and a TB endometrial biopsy. If all these are fine, then I think you should have a good chance. And it does not necessarily mean that the first embryo or the first 2 embryo transfers are successful in the very first IVF cycle. We've seen successes in subsequent cycles as well. So keep up your hope. I think it can work. Yeah.
Right. So, ma'am, one more query here. Just you told us about tuberculosis.
Yeah.
So, if a patient is detected with tuberculosis,
Yes.
so for how many months that lady need to wait before her embryo transfer?
Well, if it's been proven to be tuberculosis through the biopsies, then we usually give treatment for 9 months. And after 9 months, once it's determined that, we do a repeat sample, a repeat biopsy, and if everything else is fine, then we plan for IVF. But see, ideally in India, most of the centers, we do this endometrial biopsy for tuberculosis even before we start the cycle. So in this case, she has already undergone a laparoscopy. So probably we usually do a hysteroscopy as well. And we make sure that, the patient doesn't have tuberculosis. Only then we go for the IVF cycle. But it's not the same scenario in other countries, in Western countries, because tuberculosis is not a very common thing there. So they only test for tuberculosis when, say, subsequent IVFs have failed, repeated IVF failures, then they test for it. Otherwise, in our country, we do it regularly because so many times we just see that there are no symptoms. I mean, like people feel it's unexplained infertility, and then we do the biopsy and the TB test is positive. And anyway, the good part about this is it can be treated. If not much damage has happened, just 9 months of this drug should work for most of them.
So 9 months is the maximum time period?
Yes. Usually it clears out by then.
Okay, and after that, you need to go for a test and then opt for embryo transfer.
Yes.
I think in India, every second woman has this tuberculosis.
Well, it's not that every second woman, but it's definitely quite high. So I would say maybe 10%, not every, infertile women, yes.
In India, so much of this tuberculosis, like, is there any geographical condition or weather condition?
There are several factors why it's linked. One, because of the population, overcrowding, the hygiene. So that's why in third world countries it's more common. But then they also have this link to vitamin D deficiency, so which is again rampant in India. So all these things kind of predispose to tuberculosis, and repeated infections, because just most of them don't maintain the hygiene, or they don't realize they have an infection till things go out of hand, and they don't get help easily. As compared to people abroad, they're more aware of these things.
Right. So because in many cases, we have seen that, yes, we are under medication for tuberculosis. Okay, I think we have covered this. Assisted hatching and laser hatching between, what difference is there? How long time needed to do laser hatching to embryo?
Well, I think I've already mentioned the difference. And like I said, assisted hatching can be of several types, out of which laser hatching is one of the types of assisted hatching. So assisted hatching could be via mechanical means. It can be with the help of a chemical called acid thyroid, or it can be by the use of these lasers. Okay, so depending on what we use, it's called assisted hatching. But now laser assisted hatching is the thing that we use as far as hatching is concerned, because of the simplicity and of course the accuracy. And how
Right.
long, like I said, it usually is done on day 5 embryos. Okay, so just before transfer.
Okay, just before transfer and
We do the
hatching is.
assisted hatching and allow it to hatch, and then we transfer it. We see how effective it is.
So, how much time should be given to that window after doing this laser hatching? And
There's nothing like a fixed time frame. So usually, the embryologist takes a call as to how effective it might be. So usually we put it in on day 5 or maybe the next day, day 6. It's not like we wait for it to hatch out. We just we cause thinning of the shell so that it hatches inside, or it starts in beginning to hatch. So we can visualize this process, in which case we transfer it within a couple of hours.
okay, fine. So this was a bit confusion between
Yeah.
many members that how do we proceed with this? Uh, let's take another one. My age 30 years, 2019, I have done my 2 donor egg IVFs. Those are got not successful. Second IVF they have done with embryo glue, but not success. These 2 times IVF, they transfer 2 eggs, that is 2 embryos for me. My IVF endometrial lining is above 8 and uterus lining is also good. Recently, 1 month back, I have done my hysteroscopy. Reports are normal. I am planning for third IVF. Is really assisted or laser hatching is helpful in my case? Please give me successful tips if there are any.
Well, in this case, I'm not sure why donor eggs have been used. So usually donor eggs are considered to be quite healthy. So if the IVF has been not successful in spite of using donor eggs, then maybe you should just, I mean, they've used embryo glue and endometrial lining is also good. Then probably you could try laser assisted hatching and it could help.
Okay.
And, yeah.
Right. Because after so many like unsuccessful cycles, you should opt for this. And
And that
it
too donor cycles. So donor is something
right,
that, is associated with a good rate of fertility. Yeah.
right. So it might help you. So
Yes.
please go and ask your doctor for this technique. My age 49, small 1.3 fibroid, 5 year going on marriage. I'm trying last 5 years but not conceived. Can I conceive normally?
In your case, I'm not sure what your AMH level is. So, in any
Hmm.
person, any female, as the age crosses 35, so we have something called, there are set number of eggs in each woman. And as we age, these eggs start disintegrating or getting used in each menstrual cycle. So, at your age, I'm not sure if you have any eggs left at all because your AMH is, of course, you have not mentioned. So considering your age, I'm assuming you don't have a good AMH at all, and probably you don't have enough eggs to go ahead. And normally is definitely seems very very distant. Okay, so if at all you really want to conceive, I think you should get a AMH level done, and based on that you can take a realistic decision. So usually going by your age, we usually don't expect a natural conception. So and even if you would resort to IVF, most likely that you would probably require donor eggs. So you'll have to take a call depending on the AMH level.
Right. Because age is increasing and so is the chances of natural conception decreasing.
Yes.
I think at certain after certain period of time we should think over this whether we really want to go for any assisted fertility techniques. It's not that again and again you are every month you are trying for natural conceptions and you are not getting results.
Yes, I think we have to approach it realistically. We cannot just say, okay, everybody, I mean, cannot opt for natural methods. It's not for everyone.
Right, right. Agree. Age is 29. Periods are very irregular. and trying to go for IUI. Is it okay? And thickness is 8 mm.
Well, the uterine thickness is fine, but again, we don't have your hormonal profile here. We don't know what your AMH is. So, yes, it's if you've already tried oral ovulation induction with oral drugs, with tablets, and it hasn't worked for you, then probably it makes sense to see if you have polycystic ovaries. And usually, if the polycystic ovaries, the hormone levels and the ultrasound picture shows that the degree of PCOD is on the higher side, then depending on the size of the ovary, the AMH level, LH level, then probably I would advise an ovarian drilling before you go for IUI. But that's like a laparoscopic surgery. But if you don't want to go in for surgical interventions, you could try IUI, but it also depends on your hormone levels. So if your
Right.
hormone levels are okay, then you can probably try before going in for laparoscopy. But if not, I would say that you set these things right before going in for a IUI. Because with an IUI, you may conceive, but there is a high risk of abortions if your PCOD is really bad. So the
Right.
hormone tests are very important for us to, to make a decision which way to go.
Right. And already your periods are irregular. Then
Yes.
please, first you should see that how you could regularize your period. That is more important. So, ma'am, prior to this query, we have uh, next. She's saying that hysteroscopy report okay, but again, as
No,
doctor said,
if you're talking in terms of the fibroid, sorry, I
hmm,
think she means that 1.3 mm fibroid, is it a problem? Any which ways, a 1.3 mm fibroid is not going to cause any issue with implantation. But I just mean that it probably cannot happen naturally with your own eggs.
right,
So definitely, if you want to go in for a IVF procedure or any other procedure, I think you have a good chance that things will work out. But probably not with your eggs. That's the only thing.
right, age is the main
Yeah,
concern.
main.
One more thing, doctor, when we say that AMH is low, so AMH and age, they both go hand in hand. But yes, the lower AMH values in late 20s, is there are chances for natural conception also for such ladies like 28, 29? But yes, the AMH is on the lower side.
It depends how low the AMH is. If it's too low, then probably not. If it isn't,
It's
then
5:30.
yeah, then probably they do have a chance in conceiving. But it all
Like
depends
below
on what the
one.
value of AMH. So, see, like below 1 is considered as very low. So, between 1 to 2.5 is low AMH. So, it depends where they stand in the spectrum. So
Hmm.
naturally, maybe a little difficult. And one more thing, what we've generally noticed is when people have low AMH level, even though they may be young, there have been instances when they've conceived as well, but somehow these pregnancies don't really carry on. So they usually have miscarriages in between. So the AMH directly indicates how good the egg is. It indicates the quality of eggs, not just quantity. So
Right.
sometimes the quantity may be fine, but the quality may be compromised. So there's no way to make out which eggs are good, which are not in a natural cycle. So no harm in trying. But if your AMH is on the lower side and you're young, I would suggest that you look at some assisted fertility techniques rather than trying naturally for too long. So it depends
Right.
where in the bracket you fall. Yeah.
So everything depends on your age, your hormone levels, and yes, what you opted for. That is more important. Okay, we have to. Okay. I'm going for frozen embryo transfer. This is my second round of IVF. Should I ask for laser assisted hedging? How successful it is? If any of you have got assisted hedging, please share your experience and advices. And the age of this lady is 33 years and the AMH is 1.7.
And is it her own eggs or donor eggs? So if it is donor eggs, it's probably not necessary to go for a laser assisted hatching. But if on the
Okay.
other hand, it's her own cycle, then probably you could speak to your doctor whether you could look at laser assisted hatching, depending on whether it's available at the center. And of course the embryologist is always open to evaluate whether it requires, whether this case requires.
So, most probably with donor cycle, laser technique is not required.
Not required, because most of these donors are young and healthy, and they would have had children already, so we kind of know their fertility potential, so we know that there's not much of an issue with the egg per se, so it's unlikely that the zona is so thick that may require laser hatching. So
ma'am, she is going with her own
eggs. Yeah. So I think you could try laser assisted hatching in the next cycle, because one thing, it's a freeze thaw cycle, right? Just that process itself may sometimes cause hardening of the zona. So it's not a bad idea to speak to your fertility specialist about it.
And for above this 49 years lady query, so she's saying that her endometrium endometrium thickness is 10 mm.
Yeah, so like what I said, your uterus is quite healthy. I don't have any doubt about your uterus from what you have given me, the reports. My only issue is whether, you can do it naturally, as in you need an egg as well, right, to conceive. So whether you have eggs or no. So the AMH is very important here.
This is the same lady who is asking for hatching or not. So I have had 2 natural pregnancy, but miscarriages. One IUI failed and one IVF failed.
Okay. In your case, Banu, I would probably suggest that you also look at PGD, PGS as an option. PGS, that's called a pre-genetic screening, which is done on your embryos to see how healthy they are. In addition, we have some, additional factors called ERA, that is endometrial receptivity assay. So we usually combine these two together. So like how any seed, when you sow it, the seed has to be good as well as the soil, right? So the seed part of it, you can determine how healthy it is by doing a PGS. And the soil part of it, you can determine with an ERA. So if both these factors are fine, then we find the optimum window and then transfer the embryos along with probably laser hatching. So in this way, you're covering all the aspects and you're putting in, the best of your effort at the best of the time and under the best conditions. So probably, you can expect good results then.
So ma'am, could you please explain the major difference between PGS and PGT?
It's just a terminology difference and whom we use it. Like pre-genetic screening is in people like, who we just mentioned earlier, who had repeated IVF failure. So here we don't know the reason. So we are screening these embryos for genetic diseases and seeing whether these exist or not, whether the embryo is healthy or not. But there may be couples who already had and proven, either genetic abnormalities in themselves or have had children who had genetic abnormalities. So we know what the genetic defect in them is. So we try to diagnose if that genetic defect has been passed on to the embryos, to their offspring via the embryos. So that is called pre-genetic diagnosis. So diagnosis in people in whom we already know are suffering from genetic diseases, and screening is for people in anybody with recurrent IVF failures or, just to find out if the embryos are healthy. So we are screening them. We don't know what is the issue with it yet.
Okay. And ma'am, if we have a patient with recurrent IVF failures, so what all tests or what all things you would suggest to her?
Most likely, like I told you, if she's already done her TB endometrium test. So here again, we'll test whether the seed is fine and whether the soil is fine. So in terms of the seed, we're looking at the embryo as a whole. So the embryo again contains the egg and the sperm, right? So we test and see if the sperm is totally normal. We do a DNA fragmentation test on the sperms. And if the egg is normal or not, that again, we can easily visualize during an IVF. Apart from that, once the embryo is formed, I would suggest that we go for PGS and PGD depending on the condition. And as far as the endometrium is concerned, we can look at the ERA. So these are the additional tests which need to be done, because most of us, when we prepare a patient for IVF, we usually do most of the other things, like we do a hysteroscopy, we do a laparoscopy, and only then we look at an IVF. Well, this is not the situation in other countries, like I mentioned before. So they do an additional laparoscopy or a hysteroscopy and biopsy after 2 IVF cycles have failed. But in our country, we kind of prepare earlier itself. So probably these additional tests would be needed.
Okay. And beyond these tests like PGS, PGT, and laser hatching and all that, so what time period of gap would you suggest a patient to rest her body before FET?
You mean between one cycle to the other?
One cycle and transfer.
Well, inevitably, I would think even if you plan to go, back to back, you'll end up leaving a gap of 1 month. Now, suppose I've undergone an IVF in the current month, say January, and by the time I get my report and it's negative, so in the next cycle, then I'll have to let go of that IVF cycle. Even if I'm ready to go, that the next menstrual cycle will be used in preparing you for the frozen transfer. So only the month of March, I'll be able to do it, even if I decide to go back to back. But otherwise, apart from that, I would probably suggest that you give a month off in between, if you can.
Okay.
So it kind of washes out all the hormones, and then you look at a preparatory cycle for frozen embryo transfer.
Right. Because when I was undergoing my IVF and treatments, they were like back-to-back embryo transfer in the same cycle. So at that
Okay.
time, we never heard about this frozen embryo transfer.
Okay.
So this
Okay.
is a new technique, and I think giving more positive results also.
Yes.
So, ma'am, what is exactly the rescue ICSI?
Well, it's more of an embryological issue. So what happens is when we do ICSI procedure, we artificially inject the sperm into the egg, and we check whether it's been fertilized or not. The embryo has been fertilized or not. 1 day later. So in case of an IVF procedure, it is one step lesser than an ICSI or intracytoplasmic sperm injection, because in an IVF, we put the sperms and the eggs together in a petri dish and we expect them to fertilize spontaneously. So in ICSI, we are forcibly injecting. So in IVF, if this fertility check, like we do an IVF procedure and we check whether the eggs have been fertilized or not the next day, and if it has not been fertilized, there have been reports saying that ICSI, or this, injecting the sperm into the egg, can be done even then. So that is called rescue ICSI, where we are trying to convert a potential IVF which is likely to fail into, by rescuing that. By doing an ICSI, we probably rescue it and enable fertilization to occur. So that is called rescue ICSI.
And in which cases or under which conditions you would suggest this rescue ICSI?
Like I said, there's no hard and fast rule. There's no set rules. Set conditions where we should go for rescue ICSI. It's not like that. So it's usually done in cases where IVF has not resulted in the fertilization the next day. And probably this is crucial for the patient, as in the number of eggs are less and we don't have, enough means to have another IVF cycle. So where we can try ICSI. So in that case, we probably think this is the cycle that exists, then we can try a rescue ICSI. Because even with rescue ICSI, it's not that fertilization will occur, and if fertilization does occur, it does not necessarily mean that the embryos are going to be good enough.
Okay, so that way we can use this technique.
Yeah.
One more query regarding embryo glue.
Yeah.
We would really love to have your views about this.
Well, it's nothing as dramatic as it sounds. It doesn't mean that, okay, implantation is going to occur 100% by putting in this embryo glue. So this was just another attempt to improve. So far IVF, we have come a long way. We have been able to, bypass bad eggs by going for donors, or bad sperms for going to donor sperms. But somehow the level of failure exists at implantation. So we don't have too many means to make every embryo that we transplant. Like we've seen, people have got so many grade A embryos, but still implantation doesn't occur. So this embryo glue was created with the idea that probably it will help the embryo stick there for some time, and in the meantime it would hatch out and probably help in implantation. So it's just a very small chemical which we insert in the hope that it kind of sticks on. It's hyaluronic acid, but the fact is it's not an assured thing that such an embryo would, if we use embryo glow. Initially there were a lot of studies saying that, giving very positive reports on the outcome, but it's not really so. It's not like just using embryo glue will give you 100% guarantee that this embryo is going to implant. So it's not, it does not mean that.
It's like putting this glue over embryo and then doing transplant.
No, it's not over the embryo. We insert it into the cavity, the uterine cavity.
Okay.
Yeah.
Okay. So, ma'am, if the lady is on higher side of PCOS condition or PCOD, so would it be advisable for her to go or opt for this drilling technique?
Yes, if her, like I said, it depends on her hormones. So there are certain things that you consider in polycystic ovaries. One is the ultrasound picture. So we can measure the ovarian volume. We can see how big the ovaries are. So if they're really enlarged, really big, and then again we have the AMH level. So AMH, higher AMH is very indicative of PCOD. So there again, and then LH is another hormone. So high LH kind of gives us a very abnormal thing. It leads to abortions as well, even if the patient manages to conceive. So all these things are raised in PCOD. So if we drill the ovaries, the likelihood of these hormones returning to normal in the natural environment is improved a lot. So then if at all you go for any assisted reproductive techniques later, the chances of success are highly improved post ovarian drilling. So I would suggest that they go for it. Yeah.
So is there any side effect or something like this with this drilling technique?
Well, it's a surgical technique, right? So it does have some risks associated, as in risk of anesthesia, risk of bleeding, but these are all quite rare. So any technique, any medical technique has, we can give you a whole lot of likely complications that arise, but it's not necessarily a complicated surgery. And earlier there were, in olden days, they would drill, like put in many points on the ovaries, like drill all the possible cysts that you can see. So there was this consideration that when you do that, we use heat or cautery to do that. Okay, so there was this consideration that probably that itself damages the eggs a lot. So in people who have poor ovarian reserve, who have low AMH, so it was seeing that it led to ovarian failure itself, because you drill so many holes and then everything is burnt out. But now it's not the scenario, because we have a limited number of holes that we put on the ovary. So we might just probably give 3 to 5 drilling holes there. So that does not disrupt a lot. And even where we drill is very important. So we make sure it doesn't affect the ovarian blood supply. So we drill on the cortex, that is external surface of the ovary. So all these things are so advanced now. So it's very unlikely that we look at complications due to this procedure.
And yes, again, what you suggest about taking care of your body regarding supplements, regarding nutrition, regarding exercise or yoga, anything that you could suggest?
I think COVID has taught us a lot more, right? So all of us have realized how important it is, not just from fertility point of view, everything, health has become very, very important. So there's no second opinion about this. All of us need to get into some form of exercise, whether we are thin or fat or look fit or, whatever it is, whatever our concerns are, even if we are not having any comorbidities, I would really suggest that people look at taking up some form of exercise. Maybe it depends what suits each person's mentality. It can be any form of fitness, and diet is something that we all have to watch out. Most of us get into fad diet patterns, but personally, I believe that, if you take your local diet, what is really available in your area, and you eat, I've actually not seen a lot of people suffer from any major problems by eating your normal home cooked food in a normal balanced way. So most often all our lifestyle diseases are, because of our lifestyle. because of how we eat and what we eat. So we always don't balance that, right? So I definitely think we should all, keep an eye on all these things. And COVID has proved to us, so I think it's all the more important now.
Right.
Yeah.
So we can say that please watch what you are eating, how you are eating, when you are eating. So
Yes.
eating habits also plays a very important role.
Yes.
And we have covered the queries. Okay, one more I would like to ask, what is this down regulation?
Well, down regulations, there are several protocols in an IVF cycle. So we have the long protocol, the short protocol, ultra short protocol. So long protocol is in which the process of IVF starts one cycle before your IVF cycle. So one menstrual period before. So suppose I was planning to do your IVF in February. On day 21 of your previous cycle, I start giving you a hormone. Okay, it's a GnRH agonist, and it kind of suppresses your inner hormonal milieu, so that by the time we reach to your cycle, your IVF, the menstrual cycle in which we do your IVF, all your other hormones are suppressed, the internal hormones. So this is so that we can externally control the how we give it and how much we give, and we can, it's more under our control when this down regulation occurs. So this is what is called down regulation.
And how, like, what are the cases with you think that yes, this down regulation is important?
It's more in terms of which kind of protocol you would prefer for whom. So down regulation is a part of the long protocol. So earlier days, yes, only the long protocol existed. So now the short protocol is becoming very popular. In this, you just give hormones from day 2 of the current menstrual cycle when you're doing the IVF, and you don't have to give it for a prolonged time. So both have their own pros and cons. So short protocol is meant for some people, and long protocol is meant for some others. So it all depends. And it has been proven that short protocol is, of course, shorter in duration. So that's why it is less expensive. And another thing is that it is shown to give better, if not equal, results to the long protocol. In the long protocol, the patient has to come to the hospital or has to arrange for some way to take these injections for a long period of time, which may itself be an inconvenience. So it depends which case we were looking at. But by and large, a lot of people are going for the short protocol now.
Okay. So depending upon the cases and
Yeah.
other things.
Yeah.
So here we go. Before going to IVF, is weight management should be compulsory? My weight is 78. Please give me nutrition suggestions. What are the tips for successful IVF? I think this is a very tricky question. Tips for successful IVF.
Yeah. Anyway, weight is very, very important. Obesity is directly linked to the success of IVF. So even low weight for that matter, but in your case, your weight is, I'm assuming 78, and you're probably, if you look at the average Indian height, then probably it's your BMI is on the higher side. So yes, please go in for weight reduction. For all you know, your loss of weight itself may improve your fertility, and you may even conceive naturally if there's no other major reason. So definitely that's important. As far as nutrition tips are concerned, I think you need to meet a nutritionist or a dietitian, and they have to evaluate your body, see what the reason for your high weight is, and depending on that, they probably suggest successful IVF. There again, we need to see what else is wrong with you. So only then we can probably tell you. But if you're looking at it in the long sense, yes, exercise, diet, and a healthy lifestyle in general, sleep on time, wake up on time, eat your meals on time. So a lot of these things come into play. So, that it depends from case to case. So if we know what else is wrong with you, then probably I could give you tips for a successful IVF.
Right. And yes, as Dr. Mangla told you, you need to look for your weight. And for any weight related or nutrition query, please send us a message. And we have our in-house fertility yoga expert and in-house nutritionist. Our doctors are there to help you out. And yes, we really want your IVF to be successful. So yes, okay. So thank you, ma'am. I think we have covered lot many things. And yes, thank you so much for giving us your time and answering the whole queries. You undoubtedly cleared many misconceptions. This hatching, this assistant, this laser. One thing, because we usually get so many queries related to this. And as a layman, at times it becomes difficult for us to how to counterpart those things, and like things do happen, and yes, you cleared everything for us. So
Thank you, Purnima.
any of you, if I think I cleared
But
every doubt.
yeah, I
Hanji,
just
please.
wanted to say one thing that I know now with internet being there, a lot of people, you come to know a lot of stuff, which is why these doubts arise. Because in earlier days, nobody knew these things, right? So, but
Right.
still, somewhere I feel that you should trust your doctor or your embryologist to take the right decisions for you, and probably they would know when it is. So I might have said that, okay, you need to use laser hatching, or you might not need to use it, or whatever, but I'm pretty sure that your fertility doctor, whoever you have consulted and placed your trust, you have to probably place your entire trust, give them an opportunity to decide what is best for you. So I think that's what I would want to say. There are a lot of things on the internet, there are a lot of information, but I think these people have, I mean, we all want the best for you. So it's not like there's
Right.
any other, idea. So I'm sure that if you place your trust, things would turn out positive.
Right. And trust is a very important thing, because I believe that as much this success is important to me as a patient, as a person who is undergoing IVF or IUI, but yes, that success is also important for my doctor.
Yeah.
So there should always be this trust factor. Okay, okay, we have one more. So let's,
Yeah.
okay. Good evening, ma'am. I want to go for IVF in June 2021. When I have to consult doctor, thank you in advance. Okay.
So I think it's better that you consult the doctor at least 3 months ahead if you're going in June, so that they can run certain tests on you and prepare you. And if they have to give you any supplements, Tulsi, like folic acid or any supplement, whatever, usually we require at least 3 months for these to take effect on you, and the doctor will be able to plan it better. So if you're looking at June, probably you could meet her sometime in March. Ideally, go during your menstrual cycle, that is day 2 or day 3 of your period, and then probably it'll give them enough time to do the investigations and to prepare you generally for this process.
Right. And as before we are talking about weight, so we have another weight related query. Ma'am, I'm married for 6 years. I'm 30 now. I was 102 kgs before 3 months and now reduced to 88 kgs. I want to go for my first IVF. Please suggest me whether with this weight I should go for IVF or after reducing some more fats.
First thing, this is really remarkable. Whatever weight loss you have done is really good, because I think it's you've come a long way from 102 to 88. It's really very good. I'm quite, we don't see too many people so motivated to go so far. So yes, if you should, I mean, whether you need to go for your IVF right now, all this depends on what your current hormonal levels are. But if you ask me, I think you should probably reduce a little more. Try to get closer to your optimum BMI. Since you're only 30, it's not like you don't have time, or your age is high, so that I would say that okay, you rush in right away. But I think, considering the COVID scenario and everything else, you have time on your hands. So I would think that work on your weight a little more, try to get to your normal BMI little bit closer, and you've already done remarkably well. I'm sure you could do better, in a couple of months, and then look at an IVF.
Right, and this weight losing thing is really tough at
Yeah.
some point or the other. So please believe in yourself. इतना आपने कर लिया तो और भी कर पाएंगे. And yes, if you really need to lose this, contact us. We are here to help you. And if by any means I missed any query, please message us, and I'll just connect with Dr. Mangla Devi. So thank you, doctor. Thank you so much for giving your time and for this wonderful informative session. Thank
Thank
you.
you, Purnima. Thank you.